Hello, and welcome to today's webinar, ELSO Registry Review, the Evolution of ECMO Use in COVID-19, hosted by the Joint Perfusion COVID-19 Task Force. Thanks to our sponsor, Mark Martin of Redline Perfusion and the MSEC staff. Without you, today's webinar would not be possible. Today's broadcast will be recorded for future playback. Due to time constraints, questions will be answered through the Q&A feature at the end of the presentation in lieu of a verbal Q&A session. Please submit your questions using a Q&A function at the bottom of the Zoom presentation window. Please address your question to a specific panelist so they know to answer your question. If we do not get to your question, please consider submitting your question to the COVID-19 discussion forum linked on the Joint Perfusion COVID-19 Task Force website. We are happy to announce that the ABC has approved the Joint Perfusion COVID-19 Task Force to offer up to 1.7 Category 1 continuing education units for attendees of the live broadcast. After the conclusion of the broadcast, attendees will be provided with a link to a survey to claim credits for participation in the meeting and to provide the task force with information on the current operating status of your program. Even if you do not plan to claim credit, we would appreciate your responses to the survey. The survey link will also be sent off to attendees one day after the live broadcast. Certificates to all registered attendees will be sent within 4 weeks of the broadcast. Hi, I'm Renee Dickey, and I'm one of the 4 panelists today. I'm the co-chair of the Joint Perfusion COVID-19 Task Force, and I work at Seattle Children's Hospital in Seattle, Washington. Another one of our moderators is Lien Verkest. She is a perfusionist and ECMO coordinator at the University Hospital in Leuven, Belgium. She's also the perfusion liaison to ELSO. Another moderator is Ruben Munez, and he's retired from Innova Fairfax Hospital. He is the perfusion liaison to the Association Latin Americana de Perfusion. And finally, Justin Sleesman is here as a moderator who put this awesome webinar together. He's a perfusion liaison to ELSO. He's a pediatric perfusion at Lucile Packard Hospital, Stanford, California. Thank you, Justin.
Thank you, Renee. We are grateful that our 3 invited speakers from the Extracorporeal Life Support Organization could join for our webinar series. Christine Stead, Dr. Robert Bartlett, and Dr. Ryan Barbaro. We will start with a presentation from Christine, and my fellow panelists will introduce Dr. Bartlett and Dr. Barbaro and their content as the webinar progresses. Christine Stead is the Chief Executive Officer of ELSO and adjunct faculty at the University of Michigan School of Public Health, Health Management, and Policy. Over the last 2 years, I've seen firsthand her desire to foster communication across all specialties caring for ECMO patients, MD, and the like. Even more importantly for this audience, she's a strong advocate for non-MD direct patient care departments, including perfusionists, in carrying out the mission of ELSO. Christine's talk will focus on how perfusionists are critical team members within the ELSO organization. Christine?
Thanks so much for the introduction, Justin. I will share my screen. I have just a few slides to go through, and then we'll get to hopefully what you're really here to hear is Dr. Bartlett, of course, and Dr. Barbaro. But briefly, I want to thank AMSEC for hosting us and inviting us to participate in this. You're key partners for us. And as I was looking at our history, I wanted to just note that, of course, you're older than we are. You founded in 1964. We're a little bit younger, 1989, but trying to catch up. Anyway, this photo is one that's near and dear to ELSO as an organization. It's our founding meeting in 1989 in Ann Arbor, Michigan. This is Dr. Bartlett's idea, and it's morphed into a little bit of a bigger global community, and we're so lucky to have him as our founder and emeritus trustee now. So he's here with us, and he's here with us every day, making sure we keep his vision alive and well. One of the things I wanted to touch on just briefly is how important perfusionists are in general at ELSO and on every ECMO team everywhere in the world. So for those that don't know, there is a perfusion liaison, that's now Justin Sleesman. He sits on our steering committee, which is an important leadership, plays an important leadership and governance role in ELSO. which is now a global, as you know, we're a global organization. We have over 700 ECMO centers around the world. We have a couple thousand individual members. Our corporate partners are important as well. So there's just a nice, robust community here. And so having that seat at the table really helps influence all the work that we do as an organization. In addition to that, our perfusionists, I mean, we're a team in everything. And so all of our subcommittees, there's a role for perfusionists in all of them, helping to shape our annual meeting every year. You help us plan that agenda, what is important and what people want to hear about, but also an important role on almost all of our committees. So this is a really integrated team approach. We had almost 1,600 perfusionists attend our annual meeting last year. That was the first one that was virtual only. We'll have that one more time, and then hopefully we'll be able to move on and get back together again. But as we've come together as a team virtually, our perfusionists play an incredible role in everything that we do. And just in general, when we write a guideline, we ensure that perfusionists are part of that team. When we think about new services and what's needed, perfusionists also are at the table and helping shape that. For education and training, they're integral to all of the education and training that we do, from developing content and also delivering some of the education and training. Knowledge development, Ryan will talk a little bit later about our registry. That's a key part of some of the knowledge data that we have for new knowledge creation. And then the technology committee plays an incredibly important role in terms of what devices are out there, how they're doing, what needs to be improved. And I mentioned the conference committee already. This webinar is about ECMO in COVID-19. And so I wanted to touch on that really quickly as well, just to say the role that perfusionists help us do. As you see here, this was our dashboard as of yesterday when I was putting these slides together. We've added a little more than 20 new COVID-19 ECMO patients since then. But everything we did globally as a community involved perfusionists as a key part of that team. So in terms of communication and resource coordination, perfusionists were with us to think about how to get that done. We had several areas where we had issues with equipment sharing. I want to highlight that in particular in a second, but also hosting webinars, talking about the role of teams, how to keep staff safe, innovation in staffing models, and care of ECMO patients with this new infectious disease, as we learned about how different this was and how to do well with this disease while keeping our staff safe, and just the ongoing commitment to improving patient outcomes. So all of those aspects are really important to have perfusionists, just as they are as part of the ECMO team. They are that important as part of the ELSO team. In addition to that, Justin, it went a little step above and beyond all of that with us to help us create the ELSO supplies exchange, which this was something we were hearing about as the pandemic emerged in different parts of the world, this need for equipment and who has equipment and can we share the equipment. So I want to thank and acknowledge Justin's role in helping us lead beta testing of this platform and the features, functionality, design that went into standing up this service. Our hope is that people don't really need it again, but in terms of having a platform where you can safely ask for help if you have equipment needs and your normal supply chain operations aren't working, that is a huge thanks to Justin in particular, but just is a nice symbol, I think, of how we were able to come together and identify a need and work together to get that done. Lastly, I'll just share that beyond COVID, obviously we've learned a lot together, but these are the areas that we anticipate a continued strong partnership and really just an integrated team approach with perfusionists. Equipment innovation will always be an important area for us to come together. BARDA recently released an RFI for anticoagulation research in ECMO treatment, and several perfusion experts were critical in helping us create a response that we know was valuable for that RFI. So we'll see what comes out of that next. Cardiopulmonary technology and management, we really appreciate the advice and expertise that perfusionists bring all the time as part of your area of professional expertise. And then the multidisciplinary teamwork, of course, no one's better at that in some ways. And so you're critical there to just our ongoing commitment to that. Quality and then global collaboration are going to incredibly be important strengths for us to think about, emphasize. COVID brought us together and emphasized that probably more robustly recently, but that we know will be an important part of our future. So thank you so much for the opportunity to talk today, and I'm looking forward to any questions you all may have of me, but I'll hand it back over to Justin now, or Ruben.
Thank you, Christine. And yes, we will hand off now to Ruben to introduce Dr. Bartlett.
Hello, everyone. Thank you for joining the webinar. I am Ruben Munoz, Perfusion Liaison for Asociación Latinoamericana de Perfusión, the Latin American Perfusion Association. Please allow me to introduce our next speaker. I first made his acquaintance at a cardiac surgery meeting in Mexico City. That was my first presentation. However, I knew of Dr. Bartlett from a previous life as a respiratory therapist. He is well known to perfusionists and ECLS team members worldwide for his work on extracorporeal membrane oxygenation, first in adults and then in his progress and work moved on to infants and neonates. He graduated from medical school, University of Michigan, trained in Boston at several hospitals, and he was faculty at the University of California, Irvine. He is presently at the University of Michigan, founder and executive member of ELSO, professor of surgery, emeritus, Dr. Robert Bartlett. Dr. Bartlett, welcome.
Thank you, Ruben, very much. It's absolutely delightful to be here, and I'm trying to get to my screens. Hold on just a second. We did that 10 minutes ago and it worked really well, but it's not working now. So I'll see if I can find my PowerPoint preparation while you're working on things. Here we go. This should work. Can you see the slides here? Not yet? Try it again. So, Justin, this is what we feared, and I'm not sure why I'm not being able to get it work. I'm just looking for my computer screen, but it's not giving me that option.
Not a problem, Dr. Bartlett. Let me see if I can load it up for you. But if you want to continue and talk about your technology and your experiences, I'll load it for you as we get going here.
Good, thanks a lot.
Yes,
So I love talking to perfusionists about ECMO related stuff because you all understand the physiology really well. And as you all know from your home teams, not everybody on your team understands the physiology of perfusion. So in many cases, the biggest job of the perfusionist is to educate the rest of the people on how extracorporeal circulation works. Good. So now let's see if I can go to slideshow. There we go from the beginning. Ah, beautiful. Okay. So I'm going to briefly tell you what you already know about the history, quite a lot about what's happening right now, and a little bit about where we see this going in the future. So as you know, the cardiac heart-lung machine was very effective in the 50s, but lethal if used for longer than a couple of hours. In the 60s, several labs and companies worked on developing membrane oxygenators, which could allow prolonged extracorporeal circulation. And in the 70s, the first clinical cases were done, including the first adult in 1971, the first cardiac case in 72, and the first newborn case in 1975, which turned out to be an important case for the development of this technology. Next one, please, Justin. Great. So by 1980, we had learned that what we learned to call ECMO at that time could totally replace heart or lung function in clinical patients for days at a time, using all the components of oxygen delivery and CO2 clearance that are shown in that encased area. Next, please. So for the next 30 years of time, neonatal and pediatric ECMO was developed and became standard practice in pediatric ICUs around the world. By 2010, about 30,000 cases had been treated. And for all those cases, we used the spiral coil solid silicone rubber oxygenator designed by Ted Colabo and roller pumps. Some of you will remember that era of ECMO. During that time, ECMO in adults was studied in a few centers around the world, not very many. And there by 2010, there might be 500 cases that had been reported. And as you just heard, ELSO was established in 1989. Next, please. So the use of ECMO, as you well know, can be in veno-arterial mode, shown here in a neonate, because that's the usual approach for newborn infants. Next slide. And can be used in a veno-venous mode using a double lumen catheter with drainage and reinfusion through the same catheter, actually developed by Jay Zwischenberger in our lab in 1982. So it's been around a long time. Next. So after that 30 years of time, in 2010, two companies, German companies, built ECMO machines that were intended for ECMO. Prior to that, you had to put together components and kind of make it up. But because of that, these new systems were very safe, very, very safe with regard to blowout and utilization and long-term use, and less thrombogenic. So it really made it much easier to manage the ECMO system. We also learned that it could be managed by a single caregiver, but before that, ECMO was managed by a whole team of people, including a perfusionist, a nurse, a respiratory therapist, a handful of docs. But now with extra training, the bedside nurse, who has to be there anyway, can manage most of ECMO, but the team is very important, still standing by for emergencies and to help out. Next, please. So ECMO 1 we describe as between 1975 and 2008 or so, and the management consisted of heavy sedation, paralysis. Patients were intubated. We tried to turn down the ventilator. A specialist, who would be a perfusionist or a nurse or respiratory therapist, had to be at the bedside 24/7 because the system could break, and it did quite regularly. And we used to try to inflate the lung. We learned that was a mistake, but the biggest problem was bleeding. Because of these new devices, we moved on to a mode of care we call ECMO 2. Patients now can be awake, breathing spontaneously, managed with a tracheostomy or extubated altogether. An ICU nurse with extra training could manage the system, but there still was a big role for the ECMO team, including the perfusionists. We learned that it's a mistake to try to recruit the lung, and bleeding, although it's still the most common complication, is now controllable. It is interesting that here we are in 2021, but most adult centers have really not completely made the transition to ECMO 2. And the main reason is it requires a really thorough understanding of physiology. That's where all of you come in. Next, please. So here are the total cases in the registry as of last July, 133,000 cases. And as you can see, most of those cases are neonatal cases and pediatric cases. But in recent years, we've added a lot more adult cases. And you can see that the survival to discharge runs from 70% in neonatal pulmonary failure to 29% in ECMO for cardiac arrest in adults. Next, please. These are the types of cases in the registry over time, beginning in 1990. And as you can see, the heavy blue bars are neonatal cases, which was 80% of the experience in 1990. Now it's only about 5%. And the rest of the cases are neonatal cardiac, pediatric, cardiac and respiratory, and of course, many more adult cases in recent years. Next, please, Justin. And to emphasize that, these are the outcomes in the last 5 years only. So remember 133,000 cases, but 60,000 of those cases are only in the last 5 years. And the major growth is in adults with pulmonary and cardiac failure. Next one. And to demonstrate that, these are the adult cardiac cases by year in the registry. And you can see how this takes off in about 2010. Next, please. And the same is true for adult respiratory cases. Really began about 2010, 2011, and those cases are now the dominant types of patients managed with ECMO. These are all registry data, but it reflects the worldwide experience. Next, please. So here we are today, and how is ECMO managed now? Well, it all depends on what the indication is. For cardiac support or circulatory support, this is the algorithm these days. The indication is simply shock unresponsive to maximal treatment. And we put these patients on, we get them leveled off, and by day 2 or 3, we be sure they're fully awake and determine how the brain is. If it's not good, then the best thing to do is turn it off then before their heart and lungs get better to avoid the inevitable problems. But if the CNS is okay, the next question is the heart working? If the answer is yes, great, you're on a roll to bridge to recovery. It'll probably take another week and those patients will be fine. But if the heart's not working by day 2 or 3, it's not going to get better. So you have to ask, is the patient a transplant candidate? If the answer is no, then you have to start with the family and make plans to turn it off. There may be a role in some centers for putting in VADs as a destination, but if there's no transplant at the end of it, probably not a good plan. On the other hand, if the patient is a transplant candidate, then you go through all the steps to list them and try to get a donor, put in a VAD, and wait for a donor to arrive. Next, please. As most of you know, there are a few unique considerations for adult VA support for cardiac patients, and they're listed here. If there's some cardiac function, then you have to worry about differential oxygenation to the upper and lower body and have a way to deal with it. If there's no cardiac function, then you have to vent the left side of the heart in some way. We prefer a septostomy done in a cath lab, but Impella is being more widely used nowadays. It's important to perfuse the leg before leaving the bedside. You can access the more proximal circulation to avoid the mixing problem by using the subclavian, or I prefer the carotid actually. Many of these cases are managed with central access if they're patients who simply can't come off the pump in the OR. Next, please. So this is the current status of the respiratory support algorithm. The indications are many, but they all boil down to a PF ratio less than 80 for 6 hours, despite optimal treatment. It's important to put patients on when that 6 hours has happened, not 2 or 3 days later trying to twiddle with the dials on the ventilator. The management protocol I just described to you, but it starts out with high blood flow in sedated patients with the vent turned essentially off. And the goal is at least 80% arterial saturation. It'll never be more than 95 because of the veno-venous system, PCO2 of 40, and most importantly, keep the oxygen delivery more than 3 times oxygen consumption, which usually means managing the hemoglobin at 12 or higher. After a couple of days, we wake the patient up, we get them up and out of bed. After the lung has recovered, after 2 or 3 weeks, we wean down the blood flow to meet the goals. And when we're only supporting 50% of the gas exchange, then we trial the patient off. Next, please. We've always had this problem, but we have it much more frequently now because of COVID. The patient's alert, awake, stable on VV support, and the lungs are not working at all. As you might remember, there was a time when we simply used to turn ECMO off, thinking that the lung was permanently, irreversibly damaged. But we've learned that that's not the case. Many of those patients will recover after a period of time or can be transplanted. And this has become quite common during the COVID experience. And Ryan will tell you much more about that in a few minutes. Next, please. So there are hundreds of cases in the literature where lungs have recovered after more than 3 weeks or 4 weeks, more than a month nowadays, in both adult and pediatric cases. And here are some series, but there are case reports of total recovery after 35, 38, 117, 193 days on ECMO. The record is 605 days that this little girl, a 7-year-old, managed by Chris Nelson at Hopkins a few years ago. And if you have the opportunity to read that case report, you'll learn a lot. Quite remarkable. But now we have this phenomenon. Next slide, please. So we have learned that the lung has unexpected regenerative capacity during prolonged mechanical support, but that may be months of time on ECMO support, but then the lung recovers, usually quite quickly. It's a new phenomenon. We haven't seen this before. It creates new scientific opportunities to know when it's going to happen, why it happened, how it happened. But it also raises new practical problems because these patients will all go into right heart failure eventually, and they may be in the ICU 3 or 4 or 5 months, meaning they're filling up an ICU bed. So how can we deal with that? Next, please. So this is one of the major areas of current research in the ECMO phenomenon, designing wearable membrane lungs that the patient can wear, can be taken out of the ICU to a step-down unit, or actually can go home. This sounds a little wild, but all of you perfusionists have already lived through this with VADs. Remember when you put a VAD in a patient and they had to stay in the ICU until a donor came, and then there was a step-down unit. Now we send VAD patients home all the time, and that is coming with wearable artificial lungs for pure respiratory failure. Next, please. So that's where we stand. Here's the future as I see it. For cardiac or circulation support, we'll be doing what we're doing now, post-op patients, myocardial infarction, myocarditis, and so on. ECPR is being studied and is being quite useful in certain circumstances, usually combined with the interventional cardiology team in major hospitals. ECMO has been used and will be used much more for septic shock, for trauma, and exsanguination by hemorrhage. A trauma patient, you might imagine, and this has happened quite a lot, put on ECMO, cool down to slow the metabolism until you can get 20 units of blood and fix the bleeding site. It's also being used quite a lot for organ donation and transplantation, particularly the use of ECMO to support a cardiac dead patient as opposed to a brain dead patient, and perfusing organs. Last slide, please. The future in respiratory support is doing what we're doing now, all the things that are listed there for acute respiratory failure. And we're just getting into chronic respiratory failure, bridging to lung transplant. And what will be coming soon is wearable lungs, and also the use of CO2 removal selectively for treatment of end-stage lung disease or COPD. So thanks for your attention, and I look forward to getting your questions after Ryan's presentation.
Thank you so much, Dr. Bartlett. I think this must be the first opportunity that we have to communicate to each other without one of us falling asleep, fighting a jet lag after a long travel. Anyway, this was a very nice talk, and we couldn't be more privileged to hear a past, present, future story from the ECMO expert who has been there since the beginning and still is hugely contributing to further optimizing technology. There certainly will be questions for you, no doubt, but we first will move on to the next presenter, Dr. Ryan Barbaro. He's an assistant professor of pediatrics from the University of Michigan. As the ELSO Registry Committee Chair, Dr. Barbaro is the ideal placed person to explain us the importance of the ELSO Registry. And today his focus will be specifically directed to the role of the registry in optimizing the quality of ECMO care we provide. Dr. Barbaro has two presentations related to this subject, which he'll be presenting subsequently. The first presentation is about the importance of the ELSO registry for best practice ECMO in COVID-19. And then the second presentation is about the improvement methods which are available to us, to the ECMO centers, using both registry and arbometrics. Please go ahead, Dr. Barbaro. We are looking forward to your talks.
Thank you so much for that kind introduction. Not so much thank you for asking me to follow Christine Stead, who told us all the enormous ways that the ELSO Registry has helped us survive a pandemic, and then Dr. Bartlett, who talked to us about how he helped us create and then support patients on ECMO support. So yeah, big shoes to follow. It's okay. I just came off service and am quite accustomed to being humbled, and look forward to the opportunity, though, to share with you all the great things that we have been able to do on the backbone of the ELSO Registry, and the long-standing leadership of Dr. Bartlett. As was said, I will need two presentations to fill the shoes of the folks who came before me, but we're going to talk first just showing what we observed in the ELSO Registry. And then, because the idea here is really to describe about how we can improve care based on those observations, we'll move next into showing how the ELSO quality reporting platform powered by Arbometrics can help you really inspect your own practice and think about how that can be accomplished. As was stated, I'm the ELSO Registry Chair. Some of the science that we do is supported by some NIH funding. When we talk about COVID-19, unfortunately, it's become increasingly evident that it's a two-chapter story. And I say unfortunately because the early experience appears more positive than our secondary experience. And so when I say two chapters, obviously there's a number of ways that we could characterize COVID-19 experience. We could speak to waves, we could speak to regional differences. What I'm going to speak to is where we published our first results out of the ELSO Registry, and that was based on experience that had occurred from January 16 through May 1, 2020. That publication is shown here, and I'll review really at a glance what that showed and then kind of walk through how some of our chapter 2 compares to this chapter 1. And so in that first experience, we were really, as a consequence of the just tremendous efforts of all of our centers around the world, we were able to in real time collect data on patients that were receiving ECMO support. Thank you so much for doing that. And what we saw was that among 1,000 patients at over 200 hospitals in 36 countries, that 37% of patients died, or around the same mortality that we saw when ECMO was used to support ARDS, as documented in the EOLIA trial. We also saw, not unexpectedly, but worth confirming, that those patients that were older and those patients that had circulatory support needs in addition to their respiratory needs fared less well. As I said, though, since that time, and even as that was being published in September, it looked like outcomes were starting to shift a bit. And so what was a quite impressive number of patients now almost a year ago is another what looks like a dwarf number of almost 7,000 patients that are in the registry now. The mortality, as you can just see on the dashboard here, is clearly lower than that, the in-hospital mortality of 50% is clearly higher than the mortality that we reported of 37% in our initial study. As just a way of overview, the primary goal really of that study at that time, we didn't have a good sense of what was going on. And so our goal was really just to say, hey, in patients that need ECMO support in the setting of COVID-19, what are the overall kind of patient care characteristics, pre-ECMO care strategies and outcomes? We relied on some strengths of the ELSO data that have really been built into the registry over the last 6 years, but I'll highlight here, which is one, and some of you may have been the ones doing this, but ELSO site data managers, those who have passed kind of the ELSO data entry exam and received your training materials, are the ones entering the data. And I think that that's helped to unify our understanding of what we mean by the points of data entry. Also, there are these point of entry data assessments with error and validity checks. Certainly recognize that these can be troublesome at times when it's saying, hey, don't enter this data point, but they're really just, again, helping to increase the quality of the data. And then there's submission record validation, which just says, hey, at the point when you say, I'm going to send this on to ELSO, you just double check a few other things and make sure that none of the data is conflicting. Because we were trying to do this in real time and leverage what was going on, we used a survival analysis or a Cox proportional hazard model that really just identified and recognized that some of these patients might not have had complete follow-up. And we also used a competing risk model, which really just means that, hey, we recognize that once a patient leaves the ELSO center, we don't know exactly what happens to them. And while they may go on to live or go on to die as we're measuring, they also may have these other alternative outcomes, such as transfer to another center. So the primary outcome of this study, and what I'll also talk about in point of comparison, is the estimated cumulative incidence of in-hospital mortality 90 days after the initiation of ECMO, which is a bit of a mouthful, but it just means, hey, we can't say precisely how many patients died 90 days after they started ECMO, because we don't know 90-day outcomes for everyone. So we're estimating it. But then we're also pointing out that what we're reporting here is whether you were alive or dead in the hospital, because we don't know what happened to you once you left the hospital. And then in terms of the sample, so it's those patients that are 16 or older, so focusing on those adult patients primarily, not really talking about the MIS-C phenomenon here. They're SARS-CoV-2 positive. They went on for the first cohort kind of on or prior to May 1, and for that second cohort, it was after May 1. And then the follow-up data that's presented here is through March 1st, 2020. And so what you'll see here are patient characteristics prior to the initiation of ECMO. And so here in this first column is pretty similar to what was reported in that initial Lancet publication. There's a few more patients just because some people weren't able to enter it prior to that publication, but were subsequently. And here are those folks who had it received ECMO support after May 1st. And so a few more patients here. You can see just as we look at what the age distribution and the BMI of these patients, their gender, as well as some of these comorbidities, that there are some differences, but not huge differences. And so really with the age and the BMI being and gender being quite similar, so the number of patients that had a comorbidity of any kind is increased after May 1st. Those patients that had a diagnosis of cancer, diabetes, seems to be a bit higher, as well as does immunocompromised. Acute heart failure and acute kidney injury don't really seem substantially different. If anything, AKI is a little bit less. The occurrence of a cardiac arrest is also is similar. In terms of pre-ECMO co-infections, this looks to be actually that, there are a few more co-infections. So 59% of patients didn't have one initially, and now 52% of patients don't have one. It seems like bacterial pneumonia is really the difference here, as well as a little bit more common bloodstream infections. When we look at supportive care therapies that were delivered before ECMO support, we can also see that there seems to be a pretty substantial difference here in the way patients are supported prior to transitioning to ECMO support. And so non-invasive ventilation is even more prevalent than it was before, with 76% of patients receiving it. We can see that many patients are actually almost, a fifth of patients are receiving it more than one type of non-invasive support. So meaning like high flow nasal cannula and BiPAP, or maybe CPAP and BiPAP would also categorize that. We can see that patients are actually going on ECMO support shorter after they were placed on invasive ventilation. And we can see that the ventilation that they're receiving is, is fairly similar to what it was before. So their ventilator settings haven't changed that much. The PF ratios haven't changed all that much. Interestingly, the number of patients receiving prone positioning actually has slightly declined. Neuromuscular blockade is about the same. Vasoactive support is about the same. When we look at COVID-19 therapies, this actually is different in, I think, an important way. And so you can see that those patients receiving glucocorticoids has increased a great deal. Of course, the recovery trial was published on June 1, so after that May 1 deadline. And the hydroxychloroquine studies had already started to disprove by May 1 the value of hydroxychloroquine, but it was used quite frequently at that time, and now, of course, is used very seldomly. And then most of the support remains by far and away veno-venous ECMO support. When we look at hospital level characteristics, we can see, those centers that had done some ECMO support in the setting of COVID-19 prior to May 1st, and then those centers who had only supported patients on ECMO after May 1st for COVID-19. You can see that the distribution of the centers is not actually all that different here, with 60% of centers being from North America in both cohorts, 25% in Europe in the earlier cohort, with slightly less centers in the newer cohort. That just means that, it's not that these 25% aren't continuing to report, but that expansion of new centers was smaller in Europe. In Latin America, there was a significant expansion, and this probably partially just reflects the later onset of COVID-19 in that region of the world, or at least the higher uptick in COVID-19 exposure after May 1st in Latin America. And then you can also see the same in Asia Pacific and our SWAC chapter as well. In terms of patients, the distribution once again is relatively similar to what we were seeing before, with some differences. And then when we think about whether a patient was transferred to an ELSO center, if there was kind of before it was about 75%, now it's around 62% at those centers that are more newly delivering ECMO support. The case volume of those centers that had received patients for ECMO support in the setting of COVID-19 is a bit higher when we're talking about the 2019 volume. When we talk about the 2020 volume, this is a little bit of a different comparison, right? We're talking about centers that have been doing it longer versus centers that haven't been doing it as long, because they only started after May 1. But you can still see, obviously, there's a difference there in the experience accumulated as well. In terms of outcomes, now this isn't separating the centers. This is, just amongst centers that had done ECMO prior to May 1st, talking about what the outcomes among those centers are. So those 103 centers that we talked about here aren't included here. We're just talking about centers that did ECMO support prior to May 1st, and then those same centers, what their outcomes were after May 1st. And what you can see here is the in-hospital mortality 90 days after ECMO is substantially different. So 37.5 versus 54.1. You can see the days of ECMO support is different, as is the hospital days from ECMO to discharge being different as well. When we talk about that cumulative incidence of survival, once again, you can kind of appreciate that the mortality is a little bit different between these two groups here, and this is showing really the same thing. When we talk about the complications noted during ECMO support, you'll notice that these aren't all that different from one another, while there may be some differences from our experience in adult patients. And so the membrane lung failure may be occurring a little bit more commonly, 9 versus 12%. Circuit changes seems about the same, and the rest of these numbers at a glance you can see are relatively similar. I show this really just to show you, it doesn't look like patients are on average more sick now than they were, even acknowledging that some of those differences exist. This is just showing patients that received ECMO prior to May 1 and after May 2, and what their overall kind of risk of dying was. And so this, you can see that the risk factors kind of line up similarly across these with some minor differences. So in summary, really what mortality rate appears to be different. There is some increased steroid use, as we spoke to, increased non-invasive use, some decrease in ventilator days, and some of the hospitals that are that were doing it earlier were maybe a little more experienced actually than those that are coming on board now, but that those same hospitals that were a little bit more experienced are continuing to do ECMO with similar decline in results as well. And so what I will speak to here is just that we only have this because our community of ELSO folks around the world decided that we were going to invest effort to build understanding in the face of a pandemic where we didn't have knowledge. We were going to find time and effort where we didn't have it. And so thank you for that. And then, of course, the other thing I'll just mention is thank you to the folks who have helped us do this as well. Phil Boonstrad, Graham, and Dan have helped think about this a lot with me. And so I will now pause there and transition over to our next slide deck, which is really just about thinking a little bit more about how do we use this kind of information that we're getting from the ELSO registry to help us think about how we can improve care. And so this is a little bit of a different frame and a little bit of a different talk, but I think the two meet in the middle nicely. And so here what we're talking about is how we can think about benchmarking using the ELSO registry quality reporting platform to really investigate the care that we're delivering to patients and think about locally whether that helps us find things that we could do differently. So one of the things that I've been fortunate enough to receive training in over the last 3 years is implementation science. So I've had the opportunity to be mentored by some really wonderful people in that arena. What is implementation science? So rather than create my own words, I'll lean on those of the folks who kind of first defined this, which is it's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices in order to improve the quality and effectiveness of healthcare. So what does that mean? That means, hey, look, if we know that there's a right way to do something, how can we make sure that that right way happens, not just for my patient, but for all patients, not just at my hospital, but at all hospitals. So that's probably a little bit of a bigger thing than what ELSO is able to do. But I think what we can do is share tools that enable you at your center locally to decide how you might work to get those best practices to patients. And so one of those tools is what I'll speak to today, which is the Arbormetrics quality reporting platform. But some of that is also about thinking about how you're training your team and building and acquiring knowledge, which of course also ELSO has in terms of its educational strategies led by Dr. Bishoy. At the end of the day, though, the existence of these things only matters to the extent that you at your hospitals are able to use them. And so I present this today as a way of at least drawing attention to these strategies to help us think about how we might be able to incorporate them at our own centers. So when we talk about benchmarking, really we're talking about comparing ourselves to some standard in order to measure the quality of that care. And so here, Donna Bedian has kind of framed healthcare quality in 3 strategies. One is structure, process, and outcome. What does that mean? Structure is just the place that we give care. Process is the way that we give care, and outcome of course, is what happens after we give care. So when we talk about structure, there are 3 things that I think the ELSO registry collects and thinks about that fall into structure. One is training. So we talked a little bit about that, what we do in terms of education. Other is staffing, which we ask about in your Center of Excellence applications. And finally, location of care delivery. And so this is a place where the Arbormetrics ELSO quality reporting platform can help you. And this, I draw this to attention actually also because it's relatively new. So this here is one of our dashboards. You'll see that it's the mortality report and it's by patient cohort. And I'm just going to orient you to this in case you haven't seen it before. Also because I'm going to show a few other slides here as well related to this.
Dr. Barbaro, could I interject for one
Yeah.
moment? We lost your second presentation there, if you don't mind loading it up again. I apologize.
Did that just happen or did that happen for some time?
For some time.
All right.
I think
thank
if
you.
you go to your current slide, I think you could carry on from there.
All right. Thanks, Justin, for letting me know.
Of course.
Sorry, team. Yeah, I do think most of what I said is not too augmented by pictures, but here it does become quite relevant. So thanks again for pointing that out. Can you see it now?
Yes, we can. Could you bring it in presenter mode too, or a little in the?
Is it not in presenter mode?
It's in presenter mode there. That's good. It's still a little bit minimized, but.
Let me see.
You need slideshow from the beginning, Ryan.
Okay, I'll try that. Let me do something different. Actually, let me go try this because I've got 2 screens on. So let me just try doing it this way. Let's see if this works. Now, are you just seeing the slide?
Yes, that's good.
And all, all right. Well, thank you. So here, what I want to do is just orient you to this. So this is the ELSO Registry's quality reporting platform, which is built by a partnership with Arbormetrics. And so here you can see this is not a real hospital, though, you know, it is branded as the Peter Reiches Memorial Hospital. And so I do want to just call out also that, so what you're seeing here is a mortality cohort report. And on the left here, you can see some filters that we have. In the middle of the screen, you'll see 3 different things. One is a bar graph comparing your hospital's outcomes in this blue bar, or Peter Reiches' Memorial Hospital in this blue bar, to all of ELSO in this green. And here, what you're seeing is in quarters, but this could be annually as well. You're seeing the outcomes of patients from 2018 to 2020. And here you're seeing in Peter's hospital here in blue, relative to all other hospitals in a Caterpillar plot with the ELSO Center kind of average outcome here in green. Down below, you're seeing that we're selecting the mortality rate amongst all patients that are in this cohort of patients, but you could select just those adult patients if you so chose. You can see that at this hospital, you know, almost all of them are adults, and that's because actually we're only looking at, and if we look back to our filters, we are looking at all runs, so meaning BB or VA, but we're only looking at an adult surgical ICU here. We've got a custom time period, so that's that 2018 to 2020. It tells us that we're trending quarterly, and we have the ELSO all peer group. So here, what you can see though, is that we're focusing on adult surgical ICU. Coming back to that, when I talk about structure, the location where you're delivering care. And this really provides you an opportunity to look within a focused team about how you're doing care. Obviously, we care for different patients in different ICUs, but we also work with different team members. And so by looking down at this ICU level, you give yourself the opportunity to reflect on the care that's being provided in that ICU. Here, what I show is also at the illustrious Rikers Memorial Hospital, the pediatric performance. And so, I mean, the other thing that you have an opportunity to do is, maybe give some opportunity to have some healthy competitive competition within your hospital, look at what other folks are doing, and maybe learn from one another, even when those populations are different. So next, I'm going to talk about processes and outcomes, so the way we deliver care and what happens after. So I think if we think about it, a lot of us probably would say outcomes are what matter most. And I get that, right? As a patient, you don't care how the doctor did things necessarily as much as maybe as you care about what happens to you in the end. The problem is we have a little bit less control over what happens to patients in the end than we have over how we deliver care. And so when we focus on outcomes, the benefit is, one of the consequences is there's a lack of evidence linking the way we deliver care to that outcome. And there's also processes often are narrowly applied to specific diseases, though, which is meaning so where we gather this evidence about how to deliver care usually is from some randomized clinical trial that shows some very specific population, and so maybe you don't think it applies as broadly to all patients. Okay, so why focus on process? So outcome reporting hinges on risk adjustment, and in ECMO we don't have the best risk adjustment models. We have some, but they don't do a great job of predicting how likely a patient is to live or die. They do a good job, but maybe not good enough to take away all of the risk adjustment there. And then in terms of outcome reporting, subject to surveillance bias. So what do I mean by this? So if you don't get an MRI on all of your patients, you might be less aware of how many of them suffered an intracranial accident of some kind, whether that be a bleeding or stroke. And so you don't know for sure, but whether that outcome occurred or not. And when we talk about process metrics, the best thing about thinking about process or the way we deliver care is if you see that you're delivering care in a different way than someone else and that person's having better results, you know exactly how to change that process because it is the way you deliver care. And so you can change it to what is the recommended strategy. But first, I'm just going to focus on outcomes. And so when we talk about risk adjustment models, there are 6 risk adjustment models at the time of the launching of the ELSO Registry Quality Reporting Platform that have been published in the literature and utilized the ELSO Registry, and thus could be populated. And so all of those models underpin the risk adjustment. So here, what you'll see is that when we click on this bar, it shows that this is the adjusted and unadjusted outcomes for these patients. And it's also showing that these patients are what their outcomes are. And so by doing that, you can get a better sense of what's going on for these patients. But you don't just have to look at outcomes in terms of living or dying. They're in the quality reporting platform. We have them for each of these, whether it's neurologic, pulmonary, cardiac, renal, bleeding, hematologic, circuit related. For all of the things that you enter into the registry, we have that same kind of outcome reporting. But when I talk about processes, this is the way we're delivering care. We have introduced into the quality reporting platform 2 processes. So one is the proportion of patients that have a peak inspiratory pressure less than 25 centimeters of water. And so this is, those patients that have a peak inspiratory pressure less than 25 is based on the UK Caesar trial, as well as, the UK neonatal trial, the Caesar trial, and the Eolia trial. Each of those all did ventilator management in that way. And so what you can see here, once again, is here we've chosen for ELSO peer groups, all in this dark green, and in the light green is the center of excellence. And you can see that we're looking at a proportion of patients that have a peak inspiratory pressure of less than 25. And so here you can see amongst our adult patients at this hospital, as well as at peer institutions, at 24 hours after the initiation of ECMO, around 19% of patients have a peak inspiratory pressure less than 25. And in ELSO at large, it's around 30%, and at centers of excellence, it's around 20%. So fairly similar in terms of the proportion. I don't know that that means something like one way or another, but it gives you an idea of how you're delivering care and how you're delivering it compared to your peers. And if you think that this is a strategy that you want to change, then you can certainly see how changing that is being accomplished as you're looking over this. Similarly, we can think about what is the proportion of your patients that received eCPR amongst those patients that were in a cardiovascular ICU that are supported on either cardiac ECMO or eCPR ECMO. And once again, the same peer groups. And you can see here that, for the Peter Ricus Memorial Hospital, that's about 15% of patients amongst those had a cardiac arrest prior to going on ECMO support. Amongst all ELSO centers, it's around 24%, and amongst Center of Excellence, it's around 27%. And so the last thing that I want to let you know about is something that I'm excited in. It's just really launched. We have our first group of centers out there using this now, but we have custom peer groups available. And so the neat thing about this is really all you need to do is identify 10 centers that are willing to work with you on this. Each center can remain anonymous to one another. There is no need for a data sharing or data use agreement. You already are sending this data to ELSO into the Arbormetrics quality reporting platform. It's just allowing you to cohort yourself with other peer centers that are similarly interested. What can come of this? Well, you can have the opportunity to compare yourself to those centers, see where you can improve, as well as identify projects of interest that you as a cohort may want to work on. What do you need to do? You just each need to tell us that you're interested individually. Once that's affirmed, we can build the cohort. You can opt in or out at any time. But this really does exist. Our UK group over in the pediatric side of things it has this peer group, and they're just beginning to use it. So really excited that that's out there in the field now. And so what can you work on in that peer group? As I said, really anything that you decide that you want to that's measured in the ELSO registry. And so when we talk about using the ELSO registry to improve the care of COVID-19 patients, I really think what we're talking about doing is understanding what's going on with those patients using our data, and then using the tools at our disposal in terms of the ELSO quality reporting platform and educational structures to look at how we perform in our structure, outcomes, and processes, and find opportunities to collaborate with one another to improve that care further. That's all I have.
Thank you, Dr. Barbaro. Thanks for anchoring our webinar and sharing this valuable information as centers continue to apply ECMO support in COVID-19, and also the methods for quality improvement for those centers. We will now pivot to the Q&A session, which I know the audience is looking forward to asking these three individuals, the registry chair, the founder of ELSO, and the CEO, questions that arise during this webinar. I'll start it off. Question for Dr. Barbaro. First off is during the time of COVID and the surge in ECMO cases for COVID-19, what were the total number of registry cases? Do we see a surge in this last year, or was it compounded with the sum of cases that we were doing in COVID-19, or where are the cases now that you're seeing in the registry? Total cases.
Yeah, so I mean, it does look like there's been similar to the graphs that you saw from Dr. Bartlett, just over time, it continues to gradually increase in terms of the cases that we're seeing kind of on a monthly basis. And so, like we showed there, through May 1st, there was around 1,000 patients that have been put on ECMO. And now, a year after that, there are an additional 5,000 patients that have been put on ECMO support. And I think, that just seems to be gradually, it's a little bit harder to know exactly as those are coming on, because sometimes our community of folks enter data at kind of inflection points where we're asking them to enter data. So we see these big pushes. So around April, we told folks, we're going to have a freeze in the data. Could you enter your data? And we did see kind of a move from about that 4,000 to 6,000. That's not all patients that just went on, but obviously some of it is. And I think that a lot of it seems to also reflect the various different surges that we're having, that with delays after those surges, we see spikes in our ECMO use. Christine and Dr. Bartlett, I don't know if you have additional things that you'd like to add to that.
So my impression, of course, is that we're seeing a lot less flu and a lot less auto accidents, things that happen because of COVID, but then we've have all these COVID patients. So I don't know, Ryan, it looks like it's kind of a wash, the total number of cases this year versus last year.
I might have misheard the question, Justin. Was the question about ECMO support outside of the COVID experience, or was it about the increase in ECMO support within the COVID experience?
I think it's just the sum of the two. Are we seeing?
Yeah, then what Dr. Bartlett said is exactly right. Sorry. And I mean, it's clearly evident in the data as well. Thanks, Dr. B.
I was just wondering, oh, sorry, Justin. I was just wondering.
For Dr. Barbaro about the Arbormetrics platform and quality improvement for centers. I think this is a very interesting project that you're doing, and I like to see how it unfolds. My question is there a certain criteria for centers? Do they have to be ELSO centers to join? And also, you said that this second chapter here is peer groups, 10 centers. Do 10 centers need to approach ELSO to do this, or are you picking the 10 centers if they apply?
Nope. It's intended, so both things. One is, yes, all you need to do is be a member. You don't need to be any kind of special member, but your center needs to be a member of ELSO. Once that's accomplished, all of it is there for you. In terms of the peer groups, no, you just need to email us. As we have more and more folks getting on board, we'll probably have a slightly more formalized process for this. But all we're looking for is an email from each center just saying that they are interested in joining. It is intended to be constructed by yourselves so that you're working with folks that you have a working relationship with and hopefully collaborate on projects together.
Thank you.
So Justin, just to comment on that, Ryan showed you the so-called dashboard, and as you can see, each screen is packed with data. But that one graph called the caterpillar graph, I think, you can see where your center is compared to all the other centers you're comparing to. So if you're in the low 10% in bleeding, that's bad, then look around and see. So to me, that's the thing that's far and away the most helpful for a center, to see where I stand this month, next month, compared to all the other centers that I want to compare to.
I have a question for Christine. I was just wondering, is also doing outreach to get some of the newer, smaller, upstarting programs into ELSO, the registry, and start adding their data?
Thank you for that question, Renee. As you might recall, last year during the pandemic, we really tried to encourage new centers to join by making membership free for a year. We also made our annual conference free for a year. Just because of the moment we were in, we felt it was really important for people, especially if you're new, to make it easy to join, make it easy to participate, and make it easy to learn from other centers and from each other. So we don't have that in place currently, in terms of that ongoing free membership piece, but we are seeing more members joining, and we're looking forward to that. I think there's something unique about new programs where we can, in particular, help them, learn from experienced centers, but also from a data-driven approach. And I think what Dr. Barbaro shared around outcomes and that attention to detail for that is really important, especially if you're a new program. So between that and education and training, those are probably our best ways to support new programs.
Thank you.
Thank you.
I have a question for Christine Stead. If I may, I would like to share my screen. I have a few slides here, Christine, before we
Sure.
finalize the question here. I have here we go, and share. So I have the ELSO chapter of Latin America highlighted, 46 centers. And these 46 centers are found in these 9 countries in South America. Brazil has 15 ELSO centers and Mexico 14. So between those 2 countries, the majority of the ELSO centers are in these 2 countries. I have this question here. What would be the possibility of expanding the ELSO footprint in Latin America? However, I would define that maybe a little further. What would be the possibility of expanding the ELSO footprint in Latin America through collaboration with an organization comprised of perfusionists? And in my case, I am speaking about a LOP. However, this perfusion organization could be any other. If I may, if I can turn your attention to the map in the center. So the green dot is Mexico. The red is Central Caribbean. We have the yellow dots as the Andes region. Eastern region is Brazil, and the blue is the Southern Cone region. I have, oh, here we go. I got froze. Okay, so we have approximately about 1,500 perfusionists in those countries, and the large portion is in Brazil. The possibility of expanding this footprint in Latin America through collaboration with a LOP, say the perfusion organization, would perhaps allow a better sharing of finite resources. All the speakers here today talked about the collaboration with perfusionists, and you, Christine, also mentioned the problems with supplies, equipment, and resources, and some of the work that Justin as well had shared. The sharing of resources, and I'm using also Latin America with ALAP, these two organizations could certainly be Europe, or it could even be Asia as well. The precedent of sharing resources has already been set. ELSO and AMSEC have shared national meetings in the past. Any thoughts on maybe perhaps pursuing more of this in the future?
Well, that's probably the easiest question I'll get today. So thank you for that. I would say yes. I don't see a reason why we do anything but say that's a fantastic idea. Thank you so much for bringing that up. I would love to connect after this to make sure that connection happens, but also just highlight our team, ELSO LATAM has done a lot of work this year restructuring, and I think they're just well prepared to also work on this partnership with us specifically regionally. So thank you so much, Ruben. I'm excited about that.
You bet.
Go for it, Lean. You got a question?
Yes, I have many questions, but I will just divide them amongst all of us. I have a few questions first for Ryan, and I would like to go to his second talk. I thought those were excellent talks and a very valuable project. I was wondering, so which outcomes should we consider in our quest to see quality improvement? And is hospital mortality the right variable to look at when we talk of quality of life? Should it be more appropriate to look at markers of quality of life, such as neurological outcome? Because especially in the field of pediatrics, maybe. And if yes, could it be more or additionally be beneficial to look at the secondary injury to improve our quality of care?
Yeah, what a great question. So I think what I would say is two things. One is I really believe that we are going to most improve ECMO care by identifying what we think as a community are the right ways to deliver ECMO and measuring if we're actually delivering that kind of care. Because the problem is, and I think we'll all know this just immediately based on our clinical experiences, is no two ECMO patients are alike. They're so diversely different. The community of patients that we care for at our hospitals just extend from a huge age population, a huge disease process, and many, many support types. And so really the ability to develop some kind of model that somehow makes it equivalent across those different outcomes is probably not realistic in a goal. But what I understand and hear you saying is from a patient-centered perspective, what we care about even beyond that survival are the quality that we survive in. And also that we know some of the complications that occur, and maybe we can do something to minimize those complications. I think that what I would say to the second point is absolutely, if we can minimize complications, let's do that. But it might come in ways that are less clear to us. So I think when we think about bleeding complications, probably our first thought goes to, are we using anticoagulation monitoring strategies or anticoagulation delivering strategies in ways that drive at that? But if you look at the OLIA trial, for instance, the intracranial bleeding rates weren't different between the two groups. And maybe actually what's underlying that is when you initiate ECMO, something totally different from how you're anticoagulating a patient, but really just the severity of the illness of the patient. And I think by being in peer groups of smaller sizes where you're able to see, hey, we have this and you have that, kind of and think about what's going on, you might be able to identify some of those things. And it may be a different strategy for different centers as well. It may not be that there's a one size fits all here. What I think that the Arborimetrics quality reporting platform can help us do right now, when we don't have a clear direction about what is the best way of doing ECMO, is to have self-reflection and to do it in a community of people that are thinking carefully. This has worked really well across a number of places where we don't have, multiple randomized clinical trials to tell us the right way. I think, our surgical colleagues in NISQIP and other kind of national organizations have done this well along the way and seen outcomes improve. I don't know that we always need to know exactly why, but I think that close attention to our outcomes of interest in a community of interested colleagues will drive us to improvement, even without knowing exactly what are the underlying pieces. I know I didn't answer your question exactly, but I hope I got at the root.
Yes, you did, and there's a lot more stuff to think about. That I know it's not at all straightforward. But I have another question related to the first talk you gave. And it's more something I was wondering about. What we've seen in Europe is the point of age, the age group of these COVID patients. I don't know what the mean age was in the overall in the ELSO, but we've seen a huge difference within Europe. The average age, for example, in Germany of COVID patients on ECMO was 70 years, while in Italy was less than 60. So it's learned us about not only the profile of the patients, but also about the local resources, firstly, and the difference in policies, the age acceptances, which is also important because maybe in relation to the sharing equipment, which is harder for us than there between the states. But is this something that you noticed as well, that there's a big difference in places related to resources or different policies?
So I will say that, like, when you drive down at what you're talking about, like at a given country level or a given center level, that's not been something that we've looked at as much. I think that those are the kinds of things that you can certainly do in things like peer groups, right? Like, and that's exactly what the UK group did, is they said, hey, look, we are kind of obligated to work together as a country, as a group of folks within here, and we're really constrained by a lot of the same external factors and drive forward there. But I think that your point is quite valid, right? Like, we know that mortality is different based on age. What we can say is, on average, the age groups are not different between earlier and later. And like what I showed was that graphic, which we call kind of a forest plot, but it had all those diamonds and little lines across, and it was showing the pre-May one and the post-May one, and they really lined up similarly. And the reason I was showing is not to say like, hey, this risk factor or that risk factor. It's to say that they look pretty similar now than later. And so I think in a way, what I kind of hear underneath your question is, are patients sicker now than they were? And it doesn't look like that's the predominant piece, even if it's a small part of the picture. And then I know that you are also asking about, like, in terms of sharing resources and constraints about the ability to deliver care, does the fact that different patients have different risk factors impact how we care for those patients? I mean, that's a really important question, but I don't think that's a question that I should be answering. And I think ELSO can certainly and has certainly made statements about that. But I really think that the biggest thing there is a local context and thinking about, what your individual resources and your individual strains are. And then what we can add to that is what our best understanding is about what the epidemiologic risk is for a given cohort of patients.
Yes, thank you. I could go on discussing all these things for ages, but I'll give the word to somebody else because surely there are more burning questions from the other panelists.
I'll pivot over to Dr. Bartlett and extract some of your infinite wisdom here while we have your time. Your presentation, you talked about, the beginnings of ECMO, and now we're in 2.0 ECMO. And then we talked about where we're potentially going, durability, going home. I know this is happening in Europe. I remember presentations at ELSO and talking about patients that are on VV ECMO heading home to have tea and then come back to the hospital. If we get to that point, hopefully we do, what do you see as the biggest limitations now? And if you could maybe talk about what your lab is doing currently to maybe get to that next 3.0 level.
I think the main limiting factor really is education and understanding and kind of the fear of what might happen if you send a patient on ECMO out of the ICU to a step-down unit. The case in Europe you're referring to, of course, was Karolinska, and those guys are fabulous, and they can just make things happen, and we can all learn from them. But they just said, why don't we send these, like, they're the first people, why don't we wake these people up? Okay, why don't we get them out of bed? Why don't we send them home? So we just follow what the Karolinska is doing, we'd all be in good shape. There are 2 wearable artificial lungs that are now on the market in the United States, and I think in the rest of the world as well. One is made and marketed by LivaNova company, and they have a wearable. The wearable means you can put it in a backpack and carry it around. It's never going to be implantable. It's just wearable. And that company also is making and selling the so-called Pro-Tec Duo Catheter, which is a right atrial to pulmonary artery dual lumen catheter. And that's being used quite a lot, especially in the centers that are getting very good results in COVID patients because they have a lot of right ventricular failure. And if you want to get the Pro-Tec Duo, you have to buy the whole system. And now you have an ECMO system that you may or may not want to use, but it is usable, sending people out of the ICU and even potentially home. The other one is a company called Breathe, B-R-E-E-T-H, which is recently acquired by Abiomed, and they are selling it, and you can get that device, and it's similar, a little centrifugal pump attached to a membrane lung that you can attach to a double lumen catheter, or you can put it into the right atrium and pulmonary artery by thoracotomy. And they're introducing that for ECMO, and it's just going to require some centers to say, okay, this is working, I'm going to send the patient out of the ICU. So it's already moving along quite well. The thing that will make all of ECMO much easier, especially getting people out of the ICU, is to eliminate systemic anticoagulation. That's a major focus in our lab and several other labs, and we think we're, as we always say, just a couple years away from clinical application to do that.
I have a question that perhaps could be applied to all 3. Anybody could answer. I have a statement for, actually it's a recommendation from the Lancet article, and it goes like this: ELSO recommends against starting new ECMO centers for the sole purpose of treating patients with COVID. So certainly that's understandable, given the enormity of starting an ECMO program in the setting of a pandemic, my question is this recommendation against starting an ECMO center still relevant? So I'm asking this because we are more than a year into this pandemic, and COVID-19, much like the influenza virus, is here to stay. Will we be able to start formation of ECMO centers anytime soon?
Well, of course, we can't control what centers do, and they can start up. But what new centers have to realize, they read the literature, they see it, they see a picture of it, and they say this is pretty easy. But it takes at least a year for a center to say, we're going to do this, so now we're ready for the first patient. So that's the key thing. And if they're in the process of setting up and along comes a great patient and they're not ready, the results will be bad, and the whole system will fail. So you really should not start until you can do it. That means you can put animals on ECMO for a day successfully and train the whole team.
Thank you.
The other
And that
thing
makes sense.
Go ahead. Lynn.
Yes, I have a question for Dr. Bartlett. We know over the years that the ideal marriage between pump and oxygenator is the centrifugal pump, then is a low resistance oxygenator to reduce the recirculation inside. So that's already something that we learned, and also thanks to the registry with when we saw all the hemolysis in the centrifugal pump. But then I remember a discussion that I once heard between you and people from the industry, that actually we also don't need a heat exchanger in the oxygenator. Is this still a pathway you think of, or which you would advocate, that we get rid of the heat exchanger? Because we know if there is clotting, it's often at the side of the heat exchanger.
So thanks, Lean, and it's fun to see you, even at this distance. As you know, all know that you can run adult ECMO without a heat exchanger because the patient's metabolic rate is usually sufficient to maintain their body temperature. But if you're on very high flow rates, 4 or 5 liters a minute, and high sweep gas to keep the CO2 down, that will cool the patient down, and you'll either have to go to a lower flow rate or add a heat exchanger to do it. So, but it becomes kind of a moot question, because all the companies that are making oxygenators that we all use, almost all have a built-in heat exchanger with it. So although we might not need it for adults, we definitely need it for children all the time. So I think the industry is answering that for us by including the capability of heat exchange.
Okay, yes, yeah, that's true. But maybe sometimes we have to guide the industry and suggest what our needs are. What do you think is the most important or the most important priority in technological advancements which we need in our ECMO circuit, which engineers and industry should come forward to?
From my point of view, the number one priority is eliminating systemic anticoagulation.
And this is by coating the circuits?
Well, there are various systems available, but one problem is that if you coat the hollow fibers in the oxygenator, then it doesn't work. So you have to, and the oxygenator is the most thrombogenic area. So you have to have some way of anticoagulating the surface of the hollow fibers, which we are doing by putting nitric oxide in the sweep gas, and it works really well. The biggest problem is that's very expensive. So in our lab, we're working on making a nitric oxide generator that makes it very inexpensive to put nitric oxide in the sweep gas.
Okay, thank you.
For the sake of time, we've got 1 minute left. Dr. Bartlett, Dr. Barbaro, Christine, thank you so much for joining us, for joining the perfusion community. And I'll pass off to Ruben for some concluding statement.
Thank you, Justin. Thank you again for joining us on today's webinar, and thank you to our speakers. The recording of this webinar will also be posted on the Joint Perfusion Task Force website within 2 days and via YouTube live stream. At the conclusion of this call, all attendees that have joined us on their devices will be provided with a link to complete a survey, to claim credits, and provide us with feedback on the status of their program's operations. The link to the survey will also be automatically emailed to all participants 1 day after the conclusion of this webinar. We would greatly appreciate your participation in this survey to help guide our future work. Thank you again to Redline Perfusion for their sponsorship of today's webinar. If your question was not addressed today, please join the discussion on the Joint Perfusion Task Force website and post your question to the discussion forum. I will now turn to Lean, who will update us with information on the upcoming EBCP Eurofusion webinar. Lean?
Yes, oh, great. Thank you, Ruben. Thank you, first of all, to be part of this excellent webinar. It was a real privilege. And also thank you for allowing me a few minutes to introduce our Eurofusion webinar series of the European Board of Cardiovascular Perfusionists, of which the first episode will start in half an hour. The philosophy behind this series is to reach out to all European countries and offer each of them the opportunity to share their national perfusion experience, their local obstacles in their countries, and their professional achievements, which is hugely diverse all over Europe. We hope to learn from every country, not only in a scientific way, but also on a human and organizational level. And it should help us to identify each other's strengths and needs and support each other in a multi-directional way. The first episode is going to the Netherlands, and I really encourage all of you to accompany us on this exciting journey throughout Europe. Thank you very much. Hope to see you all.
Thank you all.
Thank you, everyone.
Thank you.
Thank you. Bye-bye.